I'm going. That's where you going. Um,
Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. So for the record, please note Erin Kelly is representing the Deputy Mayor Ann Williams Eisen. Dr. William Fisher is representing Deepa Avula, and Karen St. Hilaire representing Molly Wasso Paul. And Dr. Michelle Morse is representing Dr. Ashwin Vasan, all in a voting capacity. During the executive session, the board received and approved oral and written governing body submission from NYC H&H Harlem. The board also received and approved semi-annual governing body report, a written submission from NYC Health and Hospitals Jacobi, North Central Bronx. So next on the agenda is the adoption of the minutes for the Board of Directors meeting held on October 26, 2023. Are there any questions, comments, or changes? So hearing none, could I hear a motion to accept the minutes? All in favor, please say yes.
Yes.
Opposed, say no. So the minutes approved. Let me move on then to resolutions, and I'll move things around a little bit. So let's start with item number 6 in the agenda. So Dr. Calamia.
So authorizing the New York City Health and Hospitals Corporation system to execute contracts with Huron Consulting Group, Inc., Innovative Emergency Management, Inc., Witt O'Brien, LLC, and Indelible Solutions, LLC, for HERC project management services at a not-to-exceed amount of $128,500,000 for a contract term of 1 year and 2 6-month renewal options exercisable at the discretion of the system. This was presented to the Medical and Professional Affairs and Information Technology Committee on 11/2023 and was approved there for presentation to the board.
Thank you for having us today. I just wanted to say a couple of quick things at the outset, and then I'll turn to Chris Keeley to go through the presentation. So you saw us at the previous board meeting, you're seeing us today, and you're going to see us again in December. As the HERC program has continued to grow in support of the city, as we continue to see to have asylum seekers come into the city, we're going through the RFP process, which is the best way to ensure cost effectiveness and transparency at every level of service that we're offering throughout our HERCs. So we're looking forward to bringing back a series of further RFP-driven proposals next month as well. With that, I'll turn to Chris.
Hi, good afternoon. So for this proposal, what we're seeking is to engage project management firms. They help us in a wide variety of ways on the HERC program, from helping to launch new housing locations to helping to plan for and launch the arrival center a few months back. Now what we're doing is building out a case management program that's going to be really supporting families as they move from our supportive housing onto the next chapter of their lives. These sorts of project management firms help us to plan, make sure that we're running the checklist, make sure we're getting all the resources aligned so that when it's time to flip the switch to go live, everything is buttoned up. And then they help to support us through that go live into those next stages. They played a really critical role in helping us do that over those different sets of projects. And importantly, they can help us do it without needing to bring those resources internal to health and hospitals, because by design, those go lives are short-lived. We want to be able to have them engaged with us for these periods of time and then sunset, leverage those resources and then let them be. They're not intended to be long-term resources that we would otherwise perhaps bring into health and hospitals. So that's what we're looking to do here for this 24/7 project. We're currently using one existing contract. That's with Huron Consulting. The historical spend on that, we've committed $26 million and paid out $18.8 million through September. The contract prices staff on an hourly basis currently, and the hourly rates include all vendor expenses. There's no ancillary cost, and what we were looking to do was do a competitive bid to bring in additional competition, to find other vendors that might be able to help support this work. And as Dr. Long was saying, find other entities that could help us along the way here. With this contract, along with the ones that we've brought previously and anything that we'd bring going forward on the HERC space, all of these expenses will be covered by the HERC MOU with City Hall. So for RFP criteria, what we were looking at here was 3 years in business performing similar services. We wanted to see an MWBE status utilization plan or waiver request. and $5 million in annual revenue for each of the last 3 years. We need some entities that had a little bit of resources to lean on. For substantive criteria, we were looking at relevant experience, being able to do large, complex programs, particularly if they had expertise in homeless spaces or asylum seeker spaces. We were looking for readiness to deploy and cost. Could they move fast? Was it at an affordable price? As well as cultural competency and that MWBE standard that we discussed. For the evaluation committee, we had folks from ambulatory care, the HERC program, finance, as well as corporate health project advisor. The overview of the procurement: between July and August, we went to the CRC, we posted to the city record and sent directly the application to 9 vendors in late July. Shortly thereafter, bless you, the pre-proposal conference call was held, 45 vendors attended. Ultimately, in mid-August, 10 proposals were received. We're seeking here today, we're seeking here today to move forward with the 4 that were identified as the top 4 scorers by the committee at the end of August. Those 4, as were mentioned, are Huron, IEM, Witt O'Brien, and Indelible Solutions. I said a lot of this at the beginning. Really, what this is intended to do, initially, we were really just focused on providing some of those housing resources, right? The Row Hotel or Randall's Island. And over time, the scope of the project has expanded. And so these sorts of project management firms helped us, and hopefully will help us if we need to continue doing those types of things, expand and grow, or when the time comes to decommission, they would also help us to plan for some of that decommissioning potentially. So multiple vendors, what we're looking for, multiple vendors with various flexibility. Some of these are national entities. Some of them are more regional or local. Some might function better looking at data analysis, while others might be a little more on the ground. Let's look at these workflows. How do we optimize a workflow so that we can serve more people more efficiently and more cost effectively? These 4 vendors have different skill sets in that way. So depending on the needs going forward, we might look to engage one versus the other. As with all of the other contracts that we're bringing here, no work is guaranteed to any individual vendor. We're looking to partner with these 4, but that doesn't mean all 4 would get work. Doesn't mean any one would even get work, depending on how things evolve. What we're looking to do is have this resource available to us if we need it. And then over time, these project management services will be scaled down as the project scales down. On vendor diversity, you see here that the vendor diversity team set a goal of 35% for this solicitation. 2 of them are MWBEs themselves with 100% goals there. And then Huron and Witt O'Brien both meeting the 35% goals that were laid out. You see here the subcontracted scope of work for the 2 that are marked at 35%. Project management support, strategic planning and implementation, and data and report management. Some of that is sort of talking about how they might hire and recruit staff. Some of that might be some of their subcontractors that they might use for data reporting, for example, if needed. But they all have plans to get to the target at 35%. Vendor performance history, you see here with Huron Consulting. It's been marked satisfactory. We've had a good experience with them over the last year throughout this project. So again, we're seeking authorization to execute contracts with Huron, IEM, Witt O'Brien, and Indelible Solutions for HERC project management services with a not to exceed amount of $128.5 million for a contract term of 1 year with 2 6-month optional renewals. Thanks for your consideration.
Thank you. Any questions, Sari?
I have 2 questions. Who will be overseeing the vendors?
Yeah, so Dr. Long and myself, we are ultimately responsible for
I
managing.
didn't want to hear that, but go ahead.
So ultimately, we would be responsible for managing those vendors. And depending on what the needs might be, it might be one part of our operation versus another. So for example, if we were going to ask the project management firm to help us with some significant sized projects at the arrival center, there's a new go live where we've got to change operations in a big way, and we're looking to tap into that sort of support. That might be managed day to day by our arrival center team. Whereas if it was done at some of our HERCs, it might be done by that team. But ultimately, all of those teams ladder up to myself and Dr. Long.
Okay, and you used, it's growing, the baby's getting bigger, but I trust, I have faith in you. use the term project management and use the term case management. Did you mean them to be the same, or are they two different activities that they'll be performing?
That's a great clarification. I'll touch on project management for this, and I know Dr. Long has a very good framework for the big picture case management work, which we'll also be coming back to speak with you about sometime soon as well. On the project management, what we're looking for is sort of operationally minded people who can help design a workflow, who can help design how data might fit together, who can help us patch together what types of reports do we need so that we can measure the effectiveness of our program and see, are we hitting our key performance indicators? Are we on the right track? They can help us to build some of that infrastructure when we need to move really quickly. And they're sort of generalist, operational generalists in that way. They're specialists in that they're very good, but it's sort of, you can drop them into any sort of operational setting and they can bring their fundamentals to it. The case management work, I'll pass to Dr. Long, that is a specific body of work.
Yeah, so case management, in my mind, Sally, at this point in the crisis, case management needs to be a cornerstone of our approach going forward. So, in New York City to date, we've had over 145,000 asylum seekers enter into our city system. With our help, we've been able to have over 75,000, over half of them, take the next step forward and actually leave our city system. Meaning today we have a little bit over 65,000 still in our city system. In doing that, some of the ways we've done that is we've had case managers at our sites. We've helped to use the case managers to connect people to things like resettlement, like how to get the specific legal help that they would need. We've learned a lot along the way. So at this point in the crisis, we're taking all of the lessons we've learned, and to power that effort, we've actually resurveyed almost everybody at every part of our city system, from DHS to our humanitarian centers, asking the same set of questions about, have you completed these forms? Do you know people in New York City? What are your goals? And we're at the point now where, from a case management point of view, we can put an array of things together. There are the things we've learned people need in terms of being able to leave our system. And case management is the way to connect people to all of those things. So we've now done surveys. We know what people's needs are. Case managers are going to be the people going into our sites and saying, hey, can I help to connect you to resettlement opportunities, reticketing opportunities if you have a friend or family member in Chicago that you've now been able to reach, specific types of legal help so you could be able to work, or even to help you line up a job. So whatever your needs are, case management is our ability to help you meet those needs. And I view it as especially important because right now we're on the verge of being able to really connect people to what we've learned are their needs for the 75,000 people we've been able to help thus far. Let's use all of those lessons learned to help the other 65,000 we have today.
So these companies can do project management and can do case management.
Well, not exactly. So the project management piece that Chris was talking about is helping to orchestrate the case management effort.
Okay.
So the case management service
That's going to be separate contracts.
will be coming soon.
Okay. Thank you, Frida. You're ahead of me on this.
Dr. Fisher?
So use the term crisis, and it certainly is in terms of straining resources, but also there's something about the word that implies a time-limited phenomenon. Just as a layperson, I don't see any indication that this phenomenon will be time-limited. So I'm wondering if that's also the way you're seeing it and planning around it.
Yeah, and from my point of view, that's why I feel that at this point of the crisis, or of people still coming to New York City in need of help, our approach has shifted over time. And I think that's why to me, it's important to note that the focus going forward should be things like case management. That wasn't necessarily the most important thing on day one. On day one, as we all remember, we were doing our best to find a place for people to sleep that night. But now we've learned a lot, and it's time to apply all of those lessons. So I think I agree with you. I think that's part of the evolution in terms of where we are now.
You know, we talk about the services we put in place, and they're wonderful. And we're living in a bubble where there's so much other things going on and other perspectives. Managing the image of what we do is going to be absolutely critical. The demand, I don't know if the demand is going to burgeon the next go round or not, but our manageability on the imaging and all of that is important as well. We talk about doing good healthcare, and it just takes one hiccup and, you know, things go awry. So I'm just concerned that with this particular level of work, which has been really stellar, already there's beginning of people living in the street, and it was last night's press with the mayor actually, that people were not connected anymore and stuff like that. So that, you know, while you're doing all the good work, we have to kind of consider how we manage the extra bubbles that emerge from this.
Yeah, I think it's a great point. And I think, well, I'll draw a strand from what Chris was saying is that, you know, as we've created the bubble or the system we've created in New York City, we've done a few things that I think are especially remarkable that I wish other cities would do. One of them is the Arrival Center. So the Arrival Center, as Chris said, we use project management teams like we're bringing to you today to help us to move heaven and earth to get this huge new facility open on time so that we could help. And we've now helped over 80,000 people at the Arrival Center, 80,000 people.
So,
Every one of them that comes through gets screened for communicable diseases, gets screened for depression. That's something we uniquely do in New York City. We've done more than 40,000 vaccines at the Arrival Center and our humanitarian centers. Imagine if every city did that same effort, especially in Texas. The world would be a much better place. So I think the bubble for me, I wish we could, you know, give the
Blow
bubble
the
to
bubble
others to do too.
Yeah.
So thank you for your comment.
Well, I think people don't realize that the city is going to be stronger on account of this, and they see this as giving and not getting. This is getting for the city. We're going to be so much stronger as this influx goes on.
Thank you.
I just want to say, and I said over and over, as I watch you present on TV, you really stand, you know, really, mentally, I start feeling for you, you know, said, okay, yes, Ted, but you're doing a great job. Just continue to keep your composure and stay strong. This is some mentally, this is serious. You need a psychiatrist around here. Because this is some serious stuff mentally. But congratulations, you keep up the good work. And you know, if you need help, you got Dr. Pat right there.
Absolutely.
You're here. That's right. You have us. But anyway, God bless you and keep up the good work.
Believe me, I know I am strong and we are strong because H&H is one of the greatest institutions thanks to you all in the world. And I know Dr. Katz would walk through a wall for me, so.
Thank you. Okay, so,
It's very hard to follow that. And I agree completely. We've had many conversations on this. The work you're doing, it's amazing. And the great support you have from a lot of vendors to help build this up. The question I have on the project management contract, because there are others that will be coming, is their role, because it sounded like they were kind of go live things, setting up the Arrival Center, et cetera. And the cost here, you know, we saw 26 million paid so far or something to that effect. And we're now saying 128 million for this contract period. And so, you know, why do you see such a huge increase when the go live has already happened on it?
Right. And so they came on, those numbers are based on, I guess it was around October of last year through September. So a little bit short of a year. And then a period through the year, I guess by the spring, they were helping, in this instance, it was Huron. They were helping us to expand into go live work around the Arrival Center, go live work now into that case management work, helping people transition out. So over time, the scope has grown. Well, at the same time, that first piece, right, the go lives at the HERCs has shrunk. The infrastructure got built, they started shrinking there, but overall it's still larger now than it was at the beginning a year ago. So the trend line was going up. I think we've found our peak with the project management. I think that I'm optimistic that in the coming months, actually, we're going to hopefully be able to start bringing that down. This is, I think I may have said this to some folks previously. I'm optimistic that this contract will be one of the early indications for us that as our role shrinks overall, as the go lives go away, this is one of the earliest contracts that might be able to sunset. So the NTE, the not to exceed that you see here, we needed to price it for the full 2 years. I'm cautiously optimistic. We're going to need well less than that.
Because I think the case management services, Ted, that you explained, very clear as to what we need, what the functions are here. It's a little more, so really that you're basically paying for consultants, right? I mean, that's,
In effect,
it's people to help do the plan the work as we ramp up. And then, as you said, a leading indicator hopefully is that it's telling off.
I think that's right.
Exactly right.
A major unknown has always been how many new people are we talking about? Right, and I think that the inflow,
If we have to
Right.
stand where
Right.
we are.
that, that this whole thing has been so unpredictable week to week, month to month, that what if, next month there is a crisis in another country and there are 700 new people here? And right now it seems like we're in a steady state. People are arriving, people are leaving. Right, we're not developing a new set of things, but this whole situation has been so fluid that we wanted to make sure that if we do need to spend more money, that we have an appropriate vehicle that has had
Yeah,
an-
that we're
an
not in
RFP.
crisis mode doing emergency contracts.
Right,
and
right. We're trying to get out of that business of emergency contracting and say, we've gone out to the field. These are the 4 best contractors. We're not promising them any work. But we've qualified them. If we need them, we're going to call on them. We don't need them, we're not going to call on them.
Okay, so I'm gonna bring this to a close, so, the resolution, all in favor, please say yes.
Yes.
Or say no. So the resolution approved. Thank you so much for all your work, of course, and which was nicely summarized before.
We'll see you in a few weeks.
Let me move to number 7, Dr. Calamia.
Authorizing New York City Health and Hospitals Corporation, the system, to enter into a contract with New York Legal Assistance Group, NILAG, as the sole source vendor, under which NILAG will provide certain free legal services to the system's patients for 3 years for an amount not to exceed $7,862,000. This was presented to the Medical and Professional Affairs and Information Technology Committee on 11/20, where it was approved for the presentation to the board.
Great. Good afternoon, everyone. My name is Nicola Davis, and I'm joined here by the Senior Director for its Social Determinants of Health team, Emily Foote. And we are bringing to you today for renewal for your consideration, our contract with NILAG. We have had a contract with NILAG for many years now, and we'd like to continue this relationship. And I'm going to have Emily walk us through the slides.
Thanks, Nicola. Good afternoon. I'm just going to give a little bit of background on NILAG as an organization, as well as the process leading us to request authorization for this renewal. So they're a nonprofit organization, a large nonprofit who advocates for people experiencing poverty or in crisis. Their legal health division serves patients at hospitals across the city, including here at Health and Hospitals since 2002, as Nicola mentioned. The attorneys address complex social and legal needs that underlie health disparities, thereby removing barriers to better health for our patients with limited financial resources. Their work includes advocacy around housing quality and eviction prevention, appeals for Social Security and disability benefits, and connection to insurance coverage for undocumented immigrants, among other things. Services are provided on site at our acute care hospitals, as well as several of our Gotham sites, and appointments are made available to residents of our post-acute care facilities. The current contract is managed by our team in the Office of Ambulatory Care and Population Health, and it expires today, November 30th. Next slide, please. As Nicola mentioned, we've worked with NILAG for many years, and we have a robust partnership. We did want to test the market ahead of this renewal just to see what else is out there in New York City. So we issued an RFI in June. NILAG's proposal was very strong. We received a second proposal, but it wasn't nearly as comprehensive. We are really committed to building on this program that now exists. It provides tremendous value to our patients and to our staff. And our new contract is going to include some additional deliverables, including improved systems for communicating with our staff, closing the loop on referrals, standards for documentation and sharing of patient level data on outcomes, and also participation in an ongoing analysis of the return on investment to health and hospitals. Next slide, please. Just to share a little bit more detail on our solicitation, as I mentioned, we released an RFI in June. We laid out our vision for an enhanced medical legal partnership program, outlined basic deliverables that we would expect, and invited respondents to share ideas for further innovation. This NILAG submission addressed every component of our request. The second organization was only able to speak to certain pieces and could only have served a subset of our patients who are immigrants. This process led to our decision to request a sole source contract. I do want to note that our work with NILAG is supported by 2 additional city funding sources. Moya, who funds the Action NYC program at 3 health and hospitals facilities and pays NILAG approximately $1.3 million annually, as well as the City Council, who provides an additional $300,000 for the Immigrant Health Initiative clinics at 4 of our sites. So those services to immigrant patients under the other city-funded initiatives, I just want to stipulate, are in addition to the clinics that Health and Hospitals funds, which are available to all patients regardless of immigration status. In terms of pricing due diligence, most of these contract costs, which are going to increase under this contract approximately 28% from the current investment, will go to support NILAG's personnel costs. Their staff is unionized, and they recently executed a new labor agreement that included pay increases. There are some additional increases in the overall cost due to the additional deliverables that I mentioned, like the communication system and the data reporting. NILAG is a nonprofit vendor, so they are ineligible to qualify for MWBE certification, therefore excluded from those requirements. A preliminary financial analysis conducted this fall by Health and Hospitals budget team found positive return to H&H among patients who received a NILAG legal health intervention, primarily those patients who qualify for Medicaid via PruCall. Next slide, please. So I just want to highlight a few key aspects of this medical legal partnership, which has been in place for over 2 decades. Our healthcare staff receives training on how to spot health harming legal needs, so legal needs that intersect with a health need and can exacerbate each other. They also receive training on how to place referrals and connect patients to legal services. Attorneys are on site now at most of our facilities providing in-person appointments, and we also have virtual appointments available. In 2022, we served approximately 4,700 patients via the MLP, and this year we launched an innovative new system to manage the referrals and scheduling, and it lives right in our electronic medical record system. This allows our providers to place referrals directly while sitting with the patient's chart, and it gives us access to previously unavailable patient-level data. So it's all really quite exciting for us. As mentioned, while we do have a sense of the financial return to H&H through health insurance reimbursement as a result of the program, we are interested in developing a more comprehensive ROI, and we have a provision in the new contract to do so within a year of contract signing. Next slide, please. This is just the vendor performance evaluation, and as you can see, NILAG's performance has been satisfactory. In closing, we are requesting authorization to execute a contract with NILAG. The term will be 3 years with an annual performance review period, and the overall cost will not exceed $7,862,000. Thanks for letting us present, and we're happy to take any questions.
Any questions? Sally?
Actually, I asked this question earlier, and I think you may have responded to me. 2 points here. In your appendix, your 2 charts are really useful. 60%, 70% almost of the reasons for referral are immigration related. And I guess I asked whether you could break that down a little bit further, because most people would like to be citizens or permanent residents, and that's a steep hill to climb, but still 70% of clients are being referred for immigration help. So I was wondering if you could talk a little bit more about other types of immigration help.
Absolutely, thanks for the question. So I did sort of reference that there's this category of immigration screenings that NILAG does where they are looking for PruCall eligibility, which is permanent residency under color of law. a person without legal status can still qualify for full Medicaid in New York State via PRUCall. And NILAG is, immigration attorneys are able to do comprehensive legal assessments to essentially put together an argument for that eligibility based on the person's individual history of how and when they came to New York, to the United States, what their sort of family relationships are, and if there are factors that would qualify them for PRUCall. We think the data now show that approximately 20 to 30% of patients screened wind up qualifying for PRUCall. We are trying to really better understand those specific numbers. There are, as you mentioned, many other reasons that a patient of ours may be interested in speaking with an immigration attorney, including visa extensions, green card applications, different types of asylum categories, including under, people who have been victims of crime, either here or in their home country. Domestic violence, among other things, can qualify people for different forms of asylum and other immigration relief.
Serious medical illness. I think that one comes up often for us, right? Somebody who has a serious cancer that can't be treated in their home country is an example of a particularly likely one that you could get approved for someone.
It's impressive.
Yep. Sorry, go ahead.
It's impressive that almost 10% of the referrals were from physicians. I thought that was interesting.
Those numbers too, totally agree. Yeah, and just want to emphasize to Dr. Katz's point that there are riskier some immigration paths are riskier than others. And so one of the things that the attorneys are doing in collaboration with the healthcare team is to determine when does the health benefit to the patient sort of justify taking a riskier path, like pursuing a deferred, medical action.
Thank you.
Dr. Morse?
Yeah, thank you for the presentation. This is very exciting, and similar to Sally, I was actually excited to see how many community health workers referred to the service. I see it's 42 days, median days from referral to appointment, which is not that bad. I was just curious if there are other indicators of like kind of matching need to capacity, because I can imagine it's just going to grow.
So we agree with you. Good point and good question. And I think the best thing I can say now is that we are midway through developing new systems for sort of better triaging from a population health perspective. How do we prioritize among all of the patients who need immigration services? How do we really zero in on very difficult, obviously, to determine the highest level of need, but can we do that? What systems can we put in place that still protect patient safety and keep access to these appointments equitable?
Because we now have the scheduling system within Epic, so we're able to kind of balance the need across facilities with the referrals that we're getting, which is something that we didn't have before. So that's helpful in just the way we triage the care.
Barbara?
Yeah, I think I'm hearing a little bit of what we were talking about just a little bit earlier with our populations and the influx. And now with you in terms of how do you rate patients in terms of their readiness for certain parts of services and integration, and also dealing with other outside influences as well, behaviorally. That's what I was hearing.
I think hopefully I correctly understood the point, but I think this is where we benefit so much from the coordination between the attorneys with the larger care team, including social work and community health workers who can really do that more psychosocial assessment and work on assessment of readiness and also motivation with the patients to sort of prep them, manage expectations, and also prep them for steps that might need to be taken from a legal perspective.
Sounds like a really big challenge and a worthy one. Thank you.
One more question.
Well, just to comment, because I remember this contract before and I loved it, and it sounds like the data that you have now is terrific, and sounds like we're growing some of the services and really great. And I love the ROI piece of it. And so that is also terrific. And it just occurred to me when you're talking about all the immigration services, is there any connection here with like some of the asylum seekers that we would be serving that might access these legal services as well, or is that separate?
Yeah, well, I think for the asylum seekers that are seeking care at health and hospitals,
Yeah.
and we definitely have some that have engaged in care within health and hospitals, they could be referred to our NILAC team for assessments as well. So they would be a part of that patient population. Yeah.
Thank you.
Okay, let me then take this to a vote. All in favor, please say yes.
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 Both say no. Ruth, thank you so much.
Thank you.
So let me move on to the next three items. It's one presentation, so I'll read those. Authorizing the New York City Health and Hospitals Corporation, the system, to sign a 5-year license agreement with Everytable, PVC Everytable, for its use and occupancy of approximately 360 square feet of at NYC Health and Hospitals Kings for a retail food operation at an initial rate of $45 per square foot or $16,200 per year, to increase by 2% per year for a total occupancy fee over the term of $84,305, with such an agreement to be terminable by each party on 30 days notice without cost. And this was presented to a capital committee on November 20th, 2023. And then the other two is authorizing, number 9, authorizing the New York City Health and Hospitals Corporation to sign a 5-year license agreement with Everytable for its use and occupancy of approximately 468 square feet at NYC Health and Hospitals Harlem for a retail food operation at an initial rate of $50 per square foot or $23,400 per year, to increase by 2% per year for a total occupancy fee over the term of $121,775, with such agreement to be terminable by each parties on 30 days notice without cost. Also presented to the Capital Committee on November 20th. And the last one is authorizing the New York City Health and Hospitals Corporation to sign a 5-year license agreement with Everytable for its use and occupancy of approximately 500 square feet at NYC H&H Queens for a retail food operation at an initial rate of $50 per square foot or $25,000 per year, to increase by 2% per year for a total occupancy fee over the term of $130,101, with such agreement to be terminable by each party on 30 days notice without cost. Also presented to the Capital Committee November 20th. So one presentation, go ahead.
Good afternoon. I'm Leora John Tapp, Assistant Vice President for Housing and Real Estate. I'm here with Jeremy Berman, our Deputy General Counsel, and Mercedes Redwood, Assistant Vice President for Managed Services. We're here to revisit the theme of food services. We brought in May food services for Jacoby Met in South Brooklyn, and then September again for Met. We are back again to address some food services issues at Queens, Harlem, and Kings. As we mentioned previously, convenient food options are really important to our staff and patients for many reasons. Our facilities are not near retail corridors. We would like access 24/7 for food. We want healthy food options. We want affordable food options. Next slide, please. Right now, Queens, Kings, and Harlem have limited or no food choices. They participated in their own selection process to select food vendors. The facilities talk amongst themselves. They heard about the success from Everytable at Jacoby to start, and they were pleased to hear about the healthy, affordable options being offered by Everytable. Next slide, please. You can see that it's a very decentralized approach to food vendors at our facilities. We see a variety of vendors serving our patients and our staff at the different facilities. But as I mentioned earlier, people have been pleased with Everytable performance. Next slide, please. We presented Everytable earlier in the year. And Everytable is a Delaware Public Benefit Corporation, really focusing on healthy, affordable foods. And they have launched at Jacoby. They should have opened at South Brooklyn this week. And Mercedes is here today, is going to speak to the success at Jacoby and why that persuaded our 3 facilities to continue with Everytable to suit their needs.
Thanks, Leora. Good afternoon, everyone. It's really important for us to recognize that our employees have been asking for healthier options. You know, back last year, we implemented the plant-based program to our patient. And throughout the roadshow, that was pretty evident from all our employees. So today we have implemented every table at Jacoby, at Metropolitan, and as early as 2 days ago at South Brooklyn. And it's the response are raving. They have satisfied our mission of providing healthy, delicious, fresh food. There's no processed food, nothing from cans. It's all very much more on scratch cooking, clean cooking, as the term you'll hear today out in most of the eateries. What is important is that the throughput, the price point is under $10, and employees, are very, very satisfied with the food that they've received, and they do offer a wide variety that is pleasing to our employees. So with that, definitely others, as you heard Leora said, it's contagious, and they want to see this happening. I just got a call today. Woodhall now is interested.
I guess that means you'll see us again. So as Mercedes indicated, these are the price points. This is the same menu that has been implemented in the facilities and will continue to be implemented. Next slide, please. These are the details. So just to refresh, at Queens will be 500 square feet at $50 a square foot. Next slide, please. At Harlem, 468 square feet on the first floor, $50 a square foot. And the next slide, please. Kings County, 360 square feet in the first floor of the D building near the lobby at $45 a square foot. And that completes our presentation.
You any questions from board members?
We try some food?
Please, it's something you should try.
Maybe we could have them on for one of our board meetings.
Yes.
So everybody would be able to see.
But we did that with plant-based. Yeah.
Well, let's take it for a vote first. Figure that there's no other questions, so all in favor, please say yes.
Yes.
We need to go separately. Felicia. Stand like that. So, okay, bear with me, but I have three questions. That is one presentation now also. So, number 11, authorizing NYC Health and Hospitals Corporation to further increase the funding by $3,477,599 for its previously executed agreement with Array Architects, Inc. for architectural engineering services for the renovation of space at NYC H&H Bellevue Hospital and NYC H&H Woodhull Hospital in connection with the system's correctional health services initiative to treat its patients who require higher levels of care in its outposted therapeutic housing units, which follows previously funding increases of $1,814,880 authorized in November 2021 and $6,409,289 in November 2022 and $1,960,238 in May 2023, such that the funding is increased from $18,847,407 to $22,325,006. And this was presented to the Capital Committee on November 20th, 2023. And also authorizing NYC H&H to further increase the funding by $2.4 million for its previously executed agreement with ACOM USA to provide program management services at NYC Health and Hospitals Bellevue and NYC Health and Hospitals Woodhull in connection with the system's correctional health services initiative to treat its patients who require higher levels of care in its outposted therapeutic housing units, which follows previous funding increases of $1,498,738 authorized in May 2023 such that the funding is increased from $16,635,305 to $19,035,305. And this was presented to a capital committee on November 20, 2023. Then the last one is authorizing NYC H&H to further increase the funding by $43,022,528 and until April 2025 for its previously executed contract with Consigli Construction Company to serve as construction manager/builder under a guaranteed maximum price GMP structure for the construction and construction management of the system's Correctional Health Services initiative to treat its patients who require higher levels of care in its outposted therapeutic housing unit at NYC Health Hospitals Bellevue, which follows previous funding increases of $19,421,612 authorized in May 2022 and $19,638,719 authorized in May 2023, such that the current funding is increased from $159,969,414 to $202,991,942 to cover construction and construction management at Bellevue only, and to extend the contract completion date to April 30th, 2025. This was presented to the Capital Committee also in November 20th, 2023. So,
Thank you. Good afternoon, board members, Dr. Pagan and Dr. Katz. I am Manny Sayas from the Department of Facilities Development, accompanied by colleague Oscar Gonzalez from Facilities Development, Ms. Patsy Yang, Senior Vice President from Correctional Health, and Gary Chung, Assistant Vice President for Correctional Health. We will be addressing all three of these resolutions in one presentation, and I'll gladly hand this off to Oscar.
Thank you, Manny. So a little bit of a background, the Outposted Therapeutic Housing Unit, also known as OTXHU, was announced in November 2019. We have previously come to the board to get permission to enter into contract and to increase funding as it was previously slated. In the slide in front of you, it'll show you a little bit of a matrix, a diagram of the trips that we've taken to the board. And I'll just give you a quick synopsis. Back in June 2020, we brought forth Array and ACOM to be our design and our program manager for services at Bellevue and Woodhall. Those contracts, you see they're not to exceed value there. And the time allotted for them was for 5 years. So they'll expire in 2025. The next trip was November 2021, where we brought back Array and ACOM for increased funding to accelerate the program and also to enter into a base contract with the builder, the CM Builder. And you see there, not to exceed values there. The CM Builder's timeframe was to expire on March 2023. Then we returned in May 2022 for Consigli to address additional scope or changes in scope to include a sally port and an exterior elevator. So those values were approved then. In December 2022, we came back to have an approval for Array, the design consultant, for the design approvals that were done by the New York State Regulatory SCOC. And in May of this year, 2023, we brought back Array, ACOM, and Consigli for funding increase to include additional security revisions that need to be incorporated into Bellevue, and I'll talk a little bit more about those. There is a little typo on the not to exceed value for Array, so that value is in the resolution of $18,847,407. And we've requested to extend their contract to December 31st, 2023. Next slide shows you an arrangement of everything I've just said. So New York City Health and Hospitals, OFD, and our colleague CHS, we are the owners. We hired ACOM, the program manager, to oversee the entire program. They're in the middle there in orange. And on the left, you see Array. They're our design consultants doing the designs for both Bellevue and Woodhall. And then we have on the right, Consigli, our CM builder, doing the physical construction work. In the middle, you have the other subsection of this portfolio, which is the decanting at Woodhall. But just as part of this resolutions, it's just the boxes highlighted in yellow, excuse me, in amber. Justification of proposed amendments for today. We have new requirements for security operations that resulted in a pause in work or slowdown in work. And therefore, we needed to modify the design and actually some of the construction that took place. In addition to that, we had a certain level, in the event of a power outage, our emergency power was going to cover a base amount of work, but it was requested that we include additional areas under emergency power, which would include areas such as door controls, lighting, security cameras, and fire safety systems. In addition to that, patient spaces and intake areas, and also visitation areas. Because of the pause of work or the slowdown of work, now it's going to take us longer to complete the work. So therefore, we need additional time. Because of those delays, we need additional time or additional general conditions in order to be able to keep the administrative staff and the support staff through the completion of the job, as well as insurance and other type of overhead costs. The OMB has fully supported this. They have funded the project as of the last September plan. Also, since then, we have received conditional approval for these changes by New York State Regulatory SCOC. Although we have taken a lot of trips to the board and we feel confident that we're in a good place today, I cannot 100% say that we'll not be back. So we may be back for additional board requests, but we feel that we are in a good place today. Next slide shows you just a quick breakdown. Additional costs totaling $49 million just for the specific work identified at Bellevue. This is for the new security options, considerations, both for design and for construction, to amount to $13.5 million. The delays, which lead to additional general conditions, for about $9.5 million, and the additional emergency generator that we are working out the details on, and I'll go a little bit further into that later. And that's for a tune of $26 million. A little bit of pricing breakdown. The proposals that were received specifically for Array were for an increased funding of $3.5 million. That CP today is with OMB, and we're just waiting for authorization. ACOM's funding increase is going to be for $2.4 million, and that CP is also with OMB, waiting for authorization. And Consigli's increase will be $43 million. But in addition to that, we're also looking for an extension in their contract from December to April of 2025. That CP is with OMB. There's two parts to this particular program. We have the physical work that's happening on the second floor, and then we have the emergency generator, which is the additional function. So the second floor work, we are targeting to complete by November 2024. And then because of the global supply chain issues, complexities, doing generator work, this type of mechanical equipment work in today's market conditions is taking a very long time. So we're essentially backing our way into a design process. We're shopping around and seeing what manufacturers are available to get us whatever equipment we need. We're looking for about 1,600 kilowatts worth of power. So we're talking about a big component here that's very complicated. It's taken us a little, what we thought we can deliver earlier was actually going to take us a little bit longer. So we're targeting to have that portion of the work completed in February, but because of the global supply chains, we may extend it out to April. But regardless of what we do with our generator, we're still putting in measures to be able to turn over the second floor space in November of 2024. Next slide shows you the MWB utilization plan. The Array, the design consultants utilization target was at 37%. Today we are at 31%. AECOM, the program manager, their target was at 35%. They have achieved their target to date. And Consigli's utilization plan was 31%, and they have exceeded their target, and they're up to 40%. And with that concludes my presentation. I'll take any questions.
I have two things to say. Three. One, what did you estimate the cost would be for the creation per unit back in November of 2021? 2021, right. That's when everyone was on board. About how much did you think the creation of each unit would cost?
Of each unit, meaning the Bellevue?
Bellevue and Woodhull.
Well, they only had Bellevue at that time, yeah.
We only had Bellevue at that time. We negotiated with the contractor and we locked in the price for about $120 million and a time frame for them to be able to finish by March of 2023.
Okay, so how much do you estimate the cost now for the creation of each unit for Woodhull and Bellevue will be?
Just the builder?
No, altogether.
Well, I had to do that math.
Okay.
I do that
We
math
can,
really fast right now.
we'll take other questions and then you can come back to that. I'm glad that Woodhull got to do the renovations in the spaces that it needed. That was a nice announcement that was made, and it showed there's light at the end of this tunnel. We're moving forward. I know, Patsy, we'd hoped for 2024. Now it's into 2025, but it's moving forward, and that's what's important. And then I had one question. Now I'm off my soapbox. I got to remember what my last question was. It'll come to me. Thank you.
I believe we're about 240 million all in.
It was 190 initially, was it?
I think it-
What, 190 was the original estimate for Bellevue, and it's at 239 now.
Okay. Sorry, I didn't hear you.
Initially, we're at 190 for the program just at Bellevue. And today we're at
239.
approximately how much?
239.
239 million.
Almost 50 million more.
Yep. Thank you, Patsy.
Any other questions?
We talked a lot about this at Capitol, so thank you, but I thought it would be helpful to just sort of explain it. You know, it's not a usual thing for us to see you do a contract like this and then come back multiple times to amend and adjust and things like that, but there's some unusual circumstances here, and it's a very novel, terrific program that we're doing, but if it is a first-time thing, and so that demonstrates some of this of you know, why the cost is changing and then different things happening, and so it would be helpful just to explain a little bit that that's the different process here.
So, obviously, we're working on our partners at CHS, and ultimately, the program does fall under corrections and be managed by the end user, Department of Corrections. So this is not necessarily our bread and butter. You know, our business model is healthcare, and we have to essentially abide by their regulatory requirements and how they see their regulatory requirements and how they interpret their own code. So while we were aligned and we had everything approved early on, you know, in the end, it was an interpretation of their own requirements that we had to come back and amend certain components and amend the designs and the construction. So we're working well with the end users and trying to achieve something that will work both for us and for them.
Yeah. So there's the increase, Sally, that we're pointing out is, you know, it's not due to.
It's not ours, right?
Right.
This is, if I am misspeaking, you'll tell me. I think this is one of the largest, if not the largest, and certainly complex capital projects that Health and Hospitals itself, OFD, is running, rather than contracting out the whole thing. Added to that challenge that totally has stepped up to is the relationship, the nature of this project, right? It is pioneering. It is a joint effort. It is neither fully a correctional service nor is it fully a health service. So we are both. We're facing a sort of a hybrid, well, more of an aardvark. Regulatory aardvark, between corrections and correctional regulations and health and mental health regulations in terms of facility build. We have worked with the Department of Correction from the beginning, and did secure state approval for that original design that was submitted and approved, the 2020 design. And then there was, you know, there's a change in administration and new eyes from the department in terms of what security requirements were to keep patients safe. And certainly that is not our area of expertise. Security is the expertise of the department. And so there were subsequent, we paused, we needed to pause in order not to spend money that would just end up being constructing something that it would just need to be torn down again. And there were costs associated with and negotiating what was really necessary and important. And then going to the next step, which is to go back to the state and get approval. So those were the causes of delays and the changes. Again, we respect the security identification of needs with new eyes. It's for the custody and safety of patients and for the city, and that's what we did.
Thank you. Yeah. I mean, I think you guys are doing a great job. It's a very complicated process with lots of, so I appreciate that. There was one thing you did say, Oscar, that I was going to ask a question, but now I've forgotten. So I'll circle back. But thank you.
Thank you.
Okay, any other
Oh,
questions?
actually, one point. The Woodhull and NCP are a little bit now, we're not moving on a parallel track, right? So we're learning a lot from this so that,
Particularly because of the delays, the importance of the outposted units, and just getting at least one unit up, has been, it's as strong as ever. And so that's really the focus of the city, and all efforts have been, on getting Bellevue constructed and open. Certainly Woodhull and NCB are still part of the project and important to the city and the goals of the city to certainly move our most clinically vulnerable patients to a more therapeutic setting.
And a lot of the good news is that there's a lot of the lessons learned that we can incorporate from Bellevue and bring it over to Woodhull and NCB. So that's definitely our intention. We'll see what happens with those projects.
okay. And actually, just to remember my question, you said that the CP has been submitted. You wouldn't execute any contract change until it's been approved? Is that, or?
That's right. Yeah, we will not be able to. We have to first get that authorized, and then we can submit it for a registration of the controls office.
Thank you.
Okay, so let me then ask for your vote. All in favor, please say yes.
Yeah.
Both say no. Resolution passes. Thank you so much.
Thank you.
Thank you.
Number 14, Ms. Blunt.
Authorizing the New York City Health and Hospitals Corporation, the system, to execute agreements with each of the vendors, Eclat Health Solutions, Inc., First Source Solutions Limited, RTR Financial Services, MedMetric LLC, and R1 RCM Holdco, Inc., CloudMed, for the provision of account receivable services on behalf of the system for an initial period of 3 years and 2 one-year renewal options, exercisable at the discretion of the system for an amount not to exceed $53,200,000 over the potential 5-year term.
Thank you so much. I'm Robert Melican. I'm here with Jeannie Ryan, who's the Director of Vendor Partnerships. We're from Revenue Cycle Services, and we're going to be talking about our accounts receivable partners on, what are account receivable partners and how do we deploy them in Revenue Cycle Services. H&H uses vendors in accounts receivable that really for specialized claims, claims that we can't handle ourselves or best handled by a firm that is expert in that particular area. These are outside firms with knowledge and the staffing to address these targeted aspects of our accounts receivable. All of these contracts are contingency based. The partners are paid a percentage of their collections, and their rates do vary across the different lines of businesses that we'll be speaking about. The more complex the work and the resources needed to earn that revenue, the higher the contingency rate. H&H first started with contingency contracts or vendor contracts in 2018 on our legacy systems, and we transitioned them into Epic. And what we'll be talking about are 5 different types of businesses that we bundled into one RFP. Bundling as a single RFP made it much easier for our vendors to bid on multiple lines of business. And what we did put out in this RFP are workers' comp and no-fault claims. These are really very unique claims that many hospitals use specialized partners to handle. They have unique claiming rules and unique forms and a unique process outside of our regular inpatient and outpatient billing with our traditional payers. Secondary claims review. This is a firm that is evaluating our paid claims or claims with small underpayments. And what this vendor does is model our H&H contracts and the payer contracts, and they look to identify errors on a claim that might be paid, we think are paid equal, and the payer thinks is paid properly. This firm then identifies an inconsistency and says, they're interpreting the contract incorrectly or the law has changed. They identify an underpayment and then negotiate with that payer on our behalf to earn back revenue. Secondary claims review are partners that really evaluate the low dollar partners evaluate appeals or insured accounts with very low claims dollar. These are high volume of claims with a low claim balance that they address on our behalf. They have the staffing and the expertise on that. And the last bucket or line of business is self-pay. These are vendors that conduct outreach to our uninsured patients that did not engage with H&H as they went through their treatment. So these vendors have financial counselors. They're really looking to enroll patients in insurance or identify insurance that we overlooked at the time of registration. And it's really not a collections contract, but really we were looking to engage with patients to gather insurance from them. It's not to make sure that the patient pays, but to make sure that we're getting insurance or enrolling them in insurance. All of these vendors have New York State certified counselors. So on the next slide really is our current portfolio. These are our AR partners and their terms are expiring. And we're working with supply chain to extend these contracts as we transition to our new partners. And then just going on to our overview of our procurement. We have a very long procurement process, 5 different lines of business in one procurement. We required a number of different sessions for scoring and presentation with the committee. We published our RFP in May. We had 2 rounds of question and answers. We had 29 vendors attending that, and we had ultimately received 18 vendors submitted responses across the 5 lines of business, some of them in multiple lines of business. We did our scoring and our reference checks. We made sure that we had MWBE compliance, and we proceeded from there to make our recommendations to the committee. And just to kind of go through our criteria, the AR vendor is not unique to H&H. It's not bespoke for our firm. But we did have a couple of caveats. We wanted firms with New York State experience. New York State is a little bit unique. We didn't want somebody who hasn't dealt with New York State Medicaid before. And for the self-pay vendors, we did have the requirement that they had to have certified Medicaid enrollers on staff to aid with patient engagement. Did want firms that had a capacity to handle our volume of claims. So our criteria were cost, quality, and MWBE utilization. We had a large committee representation across revenue cycle services, EITS for the security components, and we had representatives from the hospitals. They have a unique perspective that sometimes us in central office might not look, but it was good to have them on our committee. On the next slide, really you'll see the firm and how they line up. ECLAT with low dollar is our low dollar vendor. And all of the firms had MWBE partners. We're pretty proud that we're achieving our goal of 30% representation for MWBE. And the MWBE firms will be either providing direct client engagement, claim engagement, or support services for the vendors. So in short, we had a very long procurement. We'll be using these vendors judiciously as possible. H&H does like to do work in-house, but there are times that we do have to use a AR partner, and we'll be using them appropriately. I'd really like to welcome any questions at this time.
I just would like to get a little bit of clarity. So on the claims we're using them for, on workman's comp and it's a disability.
No fault?
claim? No fault. We don't do that work ourselves at all.
Correct.
Is that right?
Yeah, from the claims
Okay.
perspective, yeah.
And on the other 3, we do some of that ourselves and then we're going to farm some of it out?
Yes, we do on those, we do the bulk of the work is done by H&H hospital teams.
And in terms of the dollar volume generated from the 3 that we do the bulk of the work on, maybe I missed that. How much of a recovery have we made?
It just in general terms, including the underpaid, the all of them together, we spent roughly $11 million and we earned $86 million.
I like that. Okay,
How much is
thank
that?
you.
86
And you spent 11?
for 23 for one fiscal year. Yeah.
Frida?
I was going to ask a historical spend and amount collected. I didn't expect you to have that information, but if you could provide that, but that was just on one contract. You said.
That was on all 4 for one fiscal year.
Oh, okay, got
Yeah.
it. Great, that's terrific. And the contracts are based on performance, right? So they're contingency based. If they
Correct.
And is category, the same sort of?
No, it's, each category has a different contingency rate, and it's really based on the amount of effort that that firm has to do to earn that revenue. Just generally speaking, the higher rates are on those that have the $0 underpaid. Is a significant amount of effort to earn that revenue, and they have to go out and physically identify which claim was paid improperly, whereas the somebody who's handling our regular denied claims, the high volume claim, they're given a specific, this is why this claim was underpaid and denied for payment. And it's much easier to handle that than it is to go out and proactively identify an underpaid claim.
And so is there any then or in plan to eventually bring some of this work in-house?
Yeah, it's a great question. Thank you. We always, it does cost us money to earn it. And to the extent that we can prevent a claim from going to a vendor, we do that work. I think we've been to the board in prior sessions on just lowering our denial rate. If we do not receive a denial, that means I do not have to outsource it. Or if we, the cleaner our claims are, the better we are. The faster we're getting paid, the less that we do have to send. On the $0 paid, we look at our contracts and we do learn from what these vendors are identifying. So we do strive.
Trying to slow the.
And our referral rates have decreased as well. Like in 2018, I think our referral rates were like at 40,000 monthly, and currently for insured claims we're referring out like 21,000. So it has decreased because we are learning as well what to outsource and what to keep in house.
That's great.
I suspect we'll always have a certain amount of outsourcing in this area. There is just some.
That pays for it.
Right. It's just that but it's also that there are certain specialized skills in previously denied claims, in very small claims.
Wouldn't make sense.
That we don't have the volume, right? I mean, think about just in today's meeting, how complex the mission of health and hospitals is, right? These are firms, this is their only mission, right? This is all they have to get good at, right? And so they're very good at it. I think we've done an amazing job of improving our revenue generation, and a lot of it we can do straightforwardly, and we're good at it.
Well,
but,
and the fact that referrals are going down is
yes,
evidence of that. Yeah.
But there will always be a certain portion that would be better done by specialists than by us.
I just, a really quick question. On the management letter that we got, they noted that I think they were accounts receivable that were $80 million and we'd gotten them down to like $10 million. Are these a subset of those, or is that something entirely different?
I'm not sure on the reference to the $80 million.
Oh, okay.
This is something else, so, yeah. Dr. Morse and then Dr. Calamia, I'm sorry, I'm trying to.
Thanks for the presentation. I just had a couple more questions about the self-pay vendor specifically. Because of Medicaid redeterminations and the end of the emergency, I was curious if there's anything you can say about what you're seeing in terms of trends for uninsurance rates and how you expect this to change over the course of the contract. And then the second was, I am just curious if you have any data on the average amount that folks are paying that have a bill that aren't able to somehow get into a public insurance program or NYC Care.
On the first part, on the Medicaid recertification, not exactly in my bailiwick, if you will. I understand H&H is doing well, but that will play into this as more people, if we don't recertify them, they will become self-pay. We're looking to, that's what this contract is supposed to do. If your insurance falls off, you come back to H&H. This contract, if you do not engage with H&H's financial counselors at the time of your treatment, and then you are self-pay, we're looking for this contract to engage with you.
I think I was more thinking because that change happened since July, if you've seen.
No, we haven't seen it come through right now, no.
Okay.
No. And then the second piece of that is like, what is the average bill that a person will be getting? These are predominantly emergency and small amount of clinic visits that we do send out. There are some inpatient, but very few, and it's well below $1,000 that they're getting, but that's the claim amount.
Yeah, just to get some sense of the $80 million collected, you're saying this is largely not inpatient, right? This is largely, you're saying,
Well, it includes, that was in total, so it would be, there are a number of there's 5 lines of business here, so some of it would be on the 0 and underpaid claims. That would be more inpatient. The, insured low dollar would be more outpatient.
so based on that, you have a total accounts receivable. That's obviously a portion of the total accounts receivable that's received. How would you say we stack up against the average collections for that situation? And then what happens afterwards? It just, at what point does it get written off that we no longer pursue with these companies?
So they all go through a process, and that process varies depending upon the type of claim. For a self-pay claim, that goes through 4 statements, and it will be going to this vendor at a point in time. And then after 120 days, it typically goes to bad debt, and after 4 statements. Insurance claims have a different lifespan that is much longer. There's no, if the vendor is engaged with the payer to collect those funds, that claim can stay alive with them for a long time before we eventually write it off. If they're engaged and that claim is going, we want them to still earn that funds. So they have different life cycles.
And again, is there some sort of industry sense of what percentage? I mean, obviously we have different.
Yeah, we have a
totally different group of perhaps people,
We have
but
a
it's
different
curious, is there?
our payer mix is a little bit different, and our AR varies by hospital. But we're always looking to get our AR down and make sure that our claims are paid as quickly as possible as it goes through that workflow. I don't have off the top of my head how H&H stacks up against our peers.
Okay, so let me take this to a vote. All in favor, please say yes.
Yes.
Both say no. So the resolution is approved. Thank you so much. Let me be just for 1 minute and then we'll get moving forward. So please be aware that there's a public hearing scheduled for December 13th at 4 p.m. at Jacobi Hospital in the Rotunda building, first floor auditorium, concerning the proposed lease by the NYC Health and Hospitals to the Fortune Society, Inc. for the development of Just Home, which will provide permanent residential affordable housing in Building 2 at NYC Health and Hospitals Jacobi Medical Center. The public is encouraged to register by visiting the HHC public website or by calling 212-788-3359. That's 212-788-3359. Let me move on to Vendex approvals. Since we began the process of approving contracts prior to Vendex approvals, there are 13 items on today's agenda requiring Vendex approval. 8 have that approval. There are 2 items from previous board meetings pending Vendex approval. As we last met, no approvals were received. We will continue to notify the board as outstanding Vendex approvals are received. So let's move on to the President's report, Dr. Katz.
I hope everyone had a nice Thanksgiving. We celebrated Friendsgiving with several of our skilled nursing facility residents, especially those who don't have homes. It's a nice way to celebrate the holiday. I want to tell you about 2 important appointments that we're making. After an incredible 50 years in various positions, including Chief Medical Officer for Elmhurst and Queens Hospital, Dr. Jasmine has retired from being the Chief Medical Officer, and we will have 2 new Chief Medical Officers, Dr. Laura Ivicoli, who played a huge role during the whole COVID crisis, and Dr. Dave Holson, who I know, especially the QI members of the committee, would have met many times. He is the former emergency medicine chair at Queens. They're both, 2 extraordinary individuals who are true health and hospital people who live our mission, well-loved doctors, and they'll do great, and we will look for many opportunities to celebrate Dr. Jasmine Mashapur, who's played a really incredible historic role at Elmhurst and Queens. Today, I was able to go by right before this meeting, and Natalia had organized a Nurse Excellence Award that recognized 35 nurses from across our system for the amazing work that they do. And I just think Natalia has done an amazing set of activities around promoting our nurses, empowering our nurses, educating our nurses, training our nurses, really, and they feel it. They feel that things are different and that they're getting the support and education that they always wanted to. Several of you were able to make it to the Carter 10th anniversary. I was sad that I was in clinic. Well, I wasn't sad to be in clinic, but I was sad that they was at the same time. So I didn't get to go, but I understand that there was a huge reunion of former, health and hospital leads, and I thank many of you for going and for celebrating with us. I was with the mayor on Monday morning when he did a press availability to talk about the progress on helping people with serious mental illness and homeless persons. Obviously, Health and Hospitals has been a large part of that effort by caring for the patients who come to our CPAP emergency rooms, through our hospital beds, our extended care units, and our other programs. And the mayor specifically, mentioned Health and Hospitals and the work that we're doing. We are continuing to care for the asylum seekers, as we discussed today. We will, our 16 centers are today caring for over 22,000 individuals, which again are remarkable numbers of people that we're caring for. And we run the whole arrival center, which is really the brain of the operation that then figures out where people will go, immunizes people, sets them up for medical care, gets them insurance, gets their kids enrolled in school. I think that's one of the best things that we do within this great partnership that we have with the Department of Social Services and Homeless Services and Department of Immigrant Affairs. It's really the best of the city coming together to do the right thing. We're going to expand our lifestyle medicine to Woodhull and Kings County. It's a very exciting, very popular program. We are unveiling new community murals at Queens, Kohler, Gotham, and Sydenham. We hosted artist Modesto Flaco Jimenez, public artist in residence, who spent a year working with us around gun violence. They did a adaptation of Romeo and Juliet. They did a number of, art installations. It was really quite wonderful. We celebrated, Ted for his being on the list of 40 under 40 who are successful. I'm looking myself at the list of 60 over 60. I'm sure that's coming any day now. We have our, lung cancer screening program is expanded to all of our hospitals now. We continue to broaden our mental health services for people affected by domestic and gender-based violence. Our obesity program at Bellevue received new accreditation. Lots of stuff going on the federal level. I think you read about that in the newspaper. You don't need me to go over it. But on the state level, we're awaiting the outcome of the remaining bills that passed both houses. Of the 896 bills that passed, 165 are still being considered by the governor. And we hosted our second out of 4 CMS health insurance symposiums in partnership with CMS and the New York State Department of Health. So lots going on, and I know certainly I do, and all of our staff really appreciate knowing that the board is supporting us and helping us in so many ways. So thank you for all of it.
what you do. Thank you. Any questions for Dr. Katz?
Thank you.
Thank you.
Thank you so much. So the committee and subsidiary reports, the committee and subsidiary reports were emailed to you and are in your folders for your review and submission into the record. Are there any questions or comments about the reports? Is there any old or new business to come before this board? The board meeting is adjourned. Thank you.
Okay.
Thank you.